Good morning, ladies and gentlemen. I would like to welcome you to this group discussion. My name is Isaiah Dambe. I'm one of the co-chairs, and I have my colleague here.
And I'm Mark Woodhead. I'm a respiratory physician from just up the road in Manchester.
And I'm from Malawi. I'm privileged to be in the UK for the second time. I was here 10 years ago. Our sessions, we are supposed to have 4 speakers, but one has not managed to come. So we will be having 3 speakers. And we're just on the dot. We have started on time, and we hope we also finish on time. So let me hand over to my co-chair for further deliberations.
Thank you, Isaiah. It's great to have this session on TB in underserved groups with the conference based here in Liverpool, because Liverpool and Northwest England has a particular problem with underserved groups, and managing TB in this group poses different challenges to TB in other populations. So our first speaker, Peter McPherson, is going to set the scene, I hope, with some data about underserved groups in Northwest England. Unfortunately, Paul Cleary, as you've heard, can't be here to tell us about whole genome sequencing. Jenny Walker will be our second speaker to tell us about strategies to deal with patients in these underserved groups, and she's in a particularly good position to tell us about that, as well, but I'll tell you more when I introduce her later. And then Mango Hoto, who's temporarily disappeared from the room but was here at the beginning, is going to tell us about the role of patients and patient representatives. So without further ado, I'll invite Peter to come and tell us about the epidemiology of tuberculosis in Northwest England in relation to poverty. Peter works here in Liverpool. He works for Public Health England and is a card-carrying epidemiologist by trade, so is in no better. There's nobody better to give this talk, I don't think. So over to you, Peter.
Thank you very much, Mark. So thank you to Mark and to Isaiah and to Tom Wingfield, particularly for organising this seminar session. It's a real pleasure to be here in Liverpool. So my name is Peter McPherson. I'm an academic clinical lecturer in public health here in Liverpool. I work for Public Health England in my day job, and that involves mostly doing communicable disease control, outbreak investigation, that sort of thing here in the northwest of England. And I also do research in the University of Liverpool in the tropical school here, mostly on HIV and TB, particularly with my colleague Isaiah in Malawi, where I've worked extensively as well. So it's a real pleasure to welcome you here to Liverpool, to the World Conference, into my home city. And I hope you're enjoying exploring the city so far as well. Good. So I've been asked to speak about the epidemiology of TB in the northwest of England and its relationship to poverty. So for many of you, this may be your first visit to England, and compared to many countries that we hear about during the conference where TB is highly endemic, you may be thinking England's a rich country. You know, we don't have an issue with TB here. Poverty is not an issue in England. Or alternatively, you may recall reading the books of Charles Dickens or something like that, with these descriptions of Victorian squalor. So depicted here, this is the River Thames in London, obviously not Liverpool. Death is stalking the cholera-riven River Thames, and demanding death is demanding your money or your life. So we knew about catastrophic costs way back in the 1850s, even though we're just starting talking about it now in the TB world. You may be thinking to yourself, these days are past. We don't have these sorts of poverty anymore in England. So in this presentation, I want to reflect on the fact that even in one of the richest countries in the world, there remains huge disparities of wealth and in the social determinants of health and illness. And I'm going to particularly concentrate on the relationship between poverty and tuberculosis, and hopefully demonstrate with some epidemiological data and some program data about how we can shape practice to reduce some of these health inequalities and to care for people with TB and at risk of TB. So, of course, wealth and poverty and tuberculosis have always been closely intertwined, and this is clearly illustrated in these series of pictures So up on the top, we have an illustration of a relatively wealthy woman receiving care for tuberculosis in a sanatorium in the days before anti-tuberculosis treatment. But you can see that all of her wealth in the world is not enough to save her from death stalking over her. And similarly, down in the second image, you can see the image of a bedridden individual who has got tuberculosis, again in the figure of death, stalking over him. And you can see the poverty around him with the broken window, cold, kind of desperate conditions that he's living in. So just by a way of quirk of fate, this sign actually sits outside my office, just above, and it refers to Robert Noonan, who wrote the Ragged-Trousered Philanthropist, which has been described as the first ever working class book. So Robert Noonan lived and wrote in Liverpool, and he actually died of tuberculosis in my office. Very strange quirk. So when I told my dad this, he said, I hope they wash down the desks afterwards. But yes, and it kind of reminds us that there's this real sort of narrative around poverty and tuberculosis that we've all lived with, okay, particularly in this great historical city of Liverpool. Okay, so hopefully you've all made it to Liverpool. You all know where you are. If not, this is a map showing where you are. So Liverpool's in the northwest of England. That's the area that's coloured in red here. And about 7.1 million people live in the northwest of England. About 500,000 people live in the city of Liverpool. And in the northwest of England, we've got a real mix of geographies. We've got highly densely populated urban centres such as Manchester and Liverpool, Blackburn, Preston, etc. And we also have very rural, very sparsely populated areas, particularly up in the north in Cumbria and the border with Scotland. Okay, so we're also quite a mixed population. So in the last census, 88% of people described themselves as white British. And of course, in the northwest England, we've got strong links with industry, particularly heavy industry in the Industrial Revolution, and in Liverpool, particularly with shipping, migration, and also the slave trade as well. And if you're visiting Liverpool for the first time, I would highly recommend you visit the International Slavery Museum, which is just about 2 minutes from here, and gives a real insight into how Liverpool has changed over the years. This is hopefully what you've experienced in Liverpool during this week. This is the Albert Dock, where there's been huge amounts of regeneration. If you were here 20 years ago, it would not look like this at all. And if you look closely, you can also see just up in the top right-hand corner, that is the office where Public Health England is based. Liverpool is now the fastest growing economy in England outside of London, and you can see these huge amounts of growth that's happened in this area. But of course, it's not always been like this. This is exactly the same area. This is where we are now and what it looked like in the 1980s. And it just shows the dissolution and dereliction that has been here through years of sustained government cuts through the 1970s and 1980s, and also the running down of traditional industries, the heavy industries and shipping that left the city towards the middle of last century. So the port city, Liverpool has also been very outwards looking as well, sometimes exporting large numbers of its citizens to the New World, to America, to Canada, and sometimes and quite often has welcomed people from across the world as well, particularly poor and desperate people, and especially during the great Irish potato famine of the 1840s, we had large numbers of people moving into Liverpool. With migration and industrialisation came huge amounts of urban poverty and crowding. So this is Brownlow Hill in Liverpool. This is actually where the University of Liverpool now sits. And this is where the Brownlow Hill workhouse sat. And if you've not heard of what a workhouse is before, this is where the poor and destitute people who were unable to survive were housed and worked under kind of indentured slave labour, essentially, in the 1700s and 1800s. So this was the first ever workhouse in England. Okay, and conditions in the workhouse were terrible. And within the Brownlow Hill workhouse, we have recorded outbreaks of cholera and of Irish fever, which was recognised to be tuberculosis brought in from Irish immigrants escaping the potato famine as well. And in fact, conditions in the Brownlow Hill workhouse, and particularly large outbreaks of tuberculosis, led to the establishment of the first ever medical officer for health. This is somebody appointed by the city called Dr. William Duncan, and he was appointed to try and improve the routine surveillance for infectious diseases, and to advocate for improved sanitation and public health conditions within the city. So even 40 years after Dr. Duncan's appointment, however, conditions in Liverpool still remained appalling. And the Times of London described Liverpool as squalid Liverpool in the 1880s. So you can see these are children who lived in the Brownlow Hill workhouse, and you can see the squalor. None of them have any shoes. They all appear to have significant stunting as well. So you will undoubtedly have seen this slide a number of times during this conference, and it shows a decline in tuberculosis since the 1830s, in kind of with the contemporary occurrence of lots of important pieces of public health legislation that really have had a large impact on our ability to measure infectious diseases and to track changes. So this is basically showing a huge decline in tuberculosis since the 1830s. And obviously, most of the gains were made well before we had chemotherapy for tuberculosis in 1946. So in 1830, the UK government introduced mandatory registration of births and deaths, and this is a real step forward. First time it was done anywhere in the world, and this is what has contributed to our high-quality TB data. We've been able to track TB incidence essentially since the 1830s onwards. As early as 1837, so this is just 7 years after we started recording all births and deaths, William Farr, who's one of the early pioneering epidemiologists in England, he recognized the impact that crowding had on health. So here we've got data from 2 different areas in the northwest of England. On the top we've got Liverpool, and on the bottom we've got Manchester. And within each city, they're divided into the urban area and the rural area. So on the top, we've got Liverpool, which, as you can see, is highly densely populated. So we've got 1,560 acres compared to West Derby, which at the time was a rural area. And you can see that Liverpool had about 83,000 people living per square mile compared to only 3,000 or so in West Derby. And William Farr, one of the first people to recognize the higher rates of mortality within urban areas here. And that's reflected in Liverpool and in Manchester, giving reasonably large absolute risk differences here of about 1.4%. So William Farr also did some pioneering work on estimating TB mortality rates, again back in the 1830s. And he compared those between the major urban centres of England. So here we see mortality rates from phthisis, which is an old term for tuberculosis. And he's compared the rates of mortality between Leeds, Birmingham, Manchester, London, Liverpool, and in comparison to the whole of England and Wales again. And you can see that Liverpool had an overall annual TB mortality rate of 670 per 100,000, which is the highest of all of the cities compared. Also, interestingly, we see Birmingham had higher rates of crowding compared to all of the other cities. So despite the efforts of William Duncan and others, the large majority of people in Liverpool continued to live in desperate poverty. And here we can see the conditions within a typical slum house in the city just prior to the Second World War. This single room would comprise the whole of the family living, sleeping, cooking in this single room with a separate toilet outside. And you can see evidence of the poor health amongst this family and also the significant indoor air pollution and probably mold and damp within this house as well. Even later, into the later half of the 20th century, Liverpool was recognised to be one of the poorest cities in England. This is not helped by Margaret Thatcher's policy of deliberately neglecting the city of Liverpool, which in her words would lead the city into a period of managed decline. And this directly resulted in large riots in the area of Toxteth, which is only about 2 miles from here in South Liverpool. And there was large riots against political inaction, against police brutality, and particularly towards black communities in the poor municipal areas. So when you come to see photos such as this of modern-day Liverpool, you can clearly see how far the city has come and the progress that's been made in fighting the sources of poverty and infectious diseases. However, I want to emphasize that today, even today, the pernicious effects of poverty, inequality, and disease are still present in this city. So So this is a nice infographic published a few years ago now, but it shows the relative rates of deprivation in all local communities in England in 2011. You can see that the most deprived communities in England are coloured in blue, while the least deprived are coloured in yellow. And you will note that excluding the top two most deprived communities in England, which are in Lincolnshire and Norfolk, the remainder, the last 8 most deprived communities are all in the northwest of England. And in fact, number 4 and number 6 most deprived communities are both in Liverpool City. So these are really poor communities. And if you expand out to kind of the top 30, you will find quite a lot of communities in the northwest of England featuring in the most deprived areas of England. Here's more recent data from last year showing starkly the relative rates of poverty within Liverpool. So this is the Liverpool city boundaries, basically. The dark red areas are local areas that are in the most deprived 10% of the whole country, of the whole of England. You can see the real divide in the city as well. We are somewhere about here currently, nice and light blue coloured, so we're doing relatively well in the city centre of Liverpool. But once you move into the north of the city, into areas such as Everton, Anfield, and also in the south of the city, in Speke and Garston particularly as well, you've got extremely high levels of concentrated deprivation. You can also see, compared to 2010, there's been no real changes in our rates of relative deprivation in the city either. And partly our failure to reduce inequalities in the city has been because we have been disproportionately affected by government cuts since the financial crisis of 2008 to 2009. So this map here basically shows changes in government spending power for each local area in England per head or per capita. You can see that Liverpool and other areas of the northwest England have suffered disproportionately with large cuts, over £200 per person compared to other areas of England. Moreover, unemployment is widening compared to the rest of the country. Here we can see relative rates of unemployment comparing the north of England with the south of England. And unemployment is increasing here relative to the rest of the country. And all of these factors taken together continue to demonstrate that there's a real nexus between urban deprivation, between class, between migration, and all of these factors together continue to exert a pernicious effect of poor health in the region. You may have seen this graph previously. This is from Dame Margaret Whitehead, who's done a lot of pioneering work here to try and improve poverty in Liverpool, but also across the world. So moving on to discuss some of the epidemiology of TB in the northwest of England and its relationship with poverty. Overall incidence of tuberculosis in England has shown year-on-year consecutive declines over the last 3 years, driven in part by the ambitious new National Collaborative TB strategy. And currently incidence stands at just over 10 per 100,000. You can see that we had this period where we had really no progress in reducing our TB incidence. But in recent years, that has started to change. And those recent declines have also been mirrored in the northwest of England. In the northwest of England, we've got an incidence of about 8 per 100,000 in 2015. So that equates to about 600 cases per year over the last year or so. So you can see from this map of England that the northwest region sits somewhere in the middle in terms of incidence rates for tuberculosis. Obviously, London is the outlier down here with extremely high rates of TB incidence. And over 3/4 of TB cases in London occur amongst people who were born outside of the UK. Okay, and this kind of effect of migration is also evident in the northwest of England. So here we can see time trends and the absolute numbers and incidence rates of cases of tuberculosis amongst UK-born and non-UK-born individuals. So you can see the UK-born rate of tuberculosis in yellow along the bottom has remained very low and very consistently low. However, the non-UK born rate has approximately 30 times higher than the UK-born rate of tuberculosis in the northwest. Okay. Tuberculosis also remains concentrated amongst the most deprived communities in England. So this figure here, you can see relative rates of deprivation on the x-axis. So we have the most deprived 10% of England and the least deprived 10% of England, and then our incidence rates of tuberculosis on the y-axis. And we can see that by far the highest rates of tuberculosis still occur in the most deprived regions of the country. There's clearly a strong geographical relationship with concentration of those cases amongst the poorest areas. So when we look at this on a northwest level, these are all of our cases of tuberculosis in the northwest of England between 2010 and 2014 plotted on a map. So you can see these blue dots here are basically where all of our TB cases have occurred over that 4-year period. And on the green map here, we can see relative rates of deprivation. And you can see obviously that the deprivation is standing out in Liverpool, Manchester, Preston and Blackburn sort of areas. Okay. We also looked at relative rates of deprivation in the northwest of England amongst TB cases. So these are TB cases divided into quintiles of wealth or deprivation, depending on where they lived when they were registered. Overall, out of the over 1,800 cases that were notified during this time period, 62% lived in the most deprived communities in the northwest of England. As you would expect, there was clear trends in age, with TB cases from the poorest communities in the northwest of England tending to be substantially younger than those from the most affluent communities. So here you can see that most deprived group has the youngest age group amongst TB cases, and that changes. So in the least deprived age group, you've got the older populations. And this has predominantly been driven by patterns of migration and immigration, with the large majority of people notified with TB in the most deprived areas being non-UK born, and indeed having recently entered in the UK. In contrast, cases living in the most affluent communities were predominantly UK born. And this graph is just to really illustrate that in the northwest of England, the majority of our cases are occurring amongst people who have arrived from countries such as Pakistan or India. That's either recent arrivals or arrivals from a while back with reactivation of TB. And these trends have really reflected our overall patterns of migration into the UK. Now, although these data are informative from a public health and from an epidemiological perspective to help us identify vulnerable and underserved groups, we must be really cognizant of the fact that these sorts of data can be misused by politicians and by the media and by the public as well. And hopefully Mango is going to speak to this later on. This is particularly pertinent in this period when we are in the post-Brexit era, when we've seen some pretty horrific headlines and public events as well. So we need to be very careful about how we present these data. And I'm going to go on to think about how we can sort of address these issues and try to think about inclusive interventions that can reduce inequalities and hopefully better address TB. Okay. I also just wanted to note that the UK has recently, over the last few years, scaled up efforts to undertake pre-entry screening as part of the new National Collaborative TB strategy, and this has felt to be a significant contributor to the declining overall numbers of cases in England. So I want to spend a few minutes speaking about the social risk factors for tuberculosis in the northwest of England, and I know Jenny's going to go on to speak on a lot more about this, so I won't speak too much. But we've seen earlier that the importance of social risk factors in historical terms, but these do remain pertinent today. Of particular importance in the northwest of England remain people who have been imprisoned. This is Walton Jail, or HMP Liverpool as it is now known, which is an old Victorian prison, but still receives inmates today. We have high rates of alcoholism and problem alcohol use in the northwest of England, and we also have significant amounts of individuals who inject drugs as well. And you may have seen, even just walking around the city centre in Liverpool, there are quite a number of homeless people who have significant unmet needs, particularly in this climate where there have been significant government cuts to homeless services as well. Taken together, there's often people who have experienced more than one of these social risk factors at once. And these groups represent some of the most vulnerable individuals in our society. So these are, again, data from all of England. I don't have disaggregated data for the northwest. But individuals with at least one social risk factor for tuberculosis have significantly worse treatment outcomes compared to those without social risk factors. So these are 2015 cohort outcome data for England, and they show that whilst 87% of individuals without a social risk factor for TB completed treatment, only 76% of those with at least one risk factor did so. So we've clearly got a large gap there where we're not managing to reach these patients effectively to support them to complete treatment. And that does represent a public health failing and a social failing as well. You can also see that the risk of death is substantially higher amongst individuals with social risk factors for disease as well. So I want to very briefly, before I finish, touch on some interventions that have been undertaken in the northwest of England to try and reduce some of these inequalities and to try and improve outcomes of TB care. So since 2012, we've had quarterly multidisciplinary cohort review, and this has been undertaken across the northwest of England, but on a regional footprint. So within each of the 4 regions within the northwest of England, there is a quarterly cohort review undertaken. And at cohort review, a multidisciplinary team sits down and reviews all of the new TB cases that have been notified or are due to complete treatment. And that involves TB physicians, respiratory physicians, TB nurses, epidemiologists, public health specialists, and also people from other services, even from the local authority, come and contribute as well. And the whole purpose is to audit outcomes and to identify areas for improvement. And the key Northwest TB cohort has really been recognised as a major success story in the northwest of England, and has had consistently good outcomes across a number of indicators that I'm going to show here. So what we wanted to see, we wanted to do some analysis to try and investigate whether TB outcomes as measured by the TB cohort process were affected by relative rates of deprivation. So as part of the TB cohort process, a number of indicators of quality of care were defined, and those were, for example, that all new notified TB cases should have a standard risk assessment undertaken for any problems that were identified, that they should have contacts identified and assessed, that all child contacts of TB cases should be assessed, that an HIV test should be offered, that we should have high rates of retention in care, and high rates of completion of treatment at 1 year in individuals who had not died or prior to notification. And you can see that when we stratified by levels of deprivation, actually individuals in the most deprived group seem to do as well as individuals in the least deprived group. And I think that's a real telling success story of the amount of work that the multidisciplinary team puts into managing individuals with complex social problems. And I'm hoping Jenny's going to touch on some of these issues. The amount of additional support that people will need in terms of things like additional language support, being put in touch with social services to be allowed to access benefits or housing support that they additionally need, or even simple things like nutritional support and support to get back into employment and things like that as well. Or to even more complicated interventions such as directly observed therapy for people with drug-resistant TB. So I hope I've given a bit of an overview of where we currently are in the northwest of England. We can see that there's been recent improvements in the TB epidemiology in the northwest of England, but there still exists a persistent nexus between deprivation, class, and migration. And I think we really need a comprehensive approach to TB control. That doesn't just focus on incidence rates alone, but tries to address the social determinants of tuberculosis. And that really involves improvements to ensure early access to screening, prevention, diagnosis, and treatment to lessen the impact of TB on all, but also rigorously and comprehensively using epidemiology data and cohort review data to identify areas where improvements can be made and to strengthen the multidisciplinary approach. So thank you very much for listening, and I'd be very happy to take any questions.
Peter, thank you very much. Peter's presentation is now open to discussion. If you have questions, please come forward to the microphone, and it would help if you could say who you are and where you're from.
I'm Tom Wingfield from the University of Liverpool. Thank you very much for that epic talk. It was really great to cover the history as well, to take us to the present day. I was just wondering, Peter, if you know if in any of the other regions, especially I suppose in London, if they've done any similar analysis to you, which would be extremely important to see if in other regions we're also meeting the needs of these underserved groups, and to learn from each other about the best ways to do that.
Yeah, thanks, Tom. That's a good question. So we were in the northwest of England, the first region. So England is divided up into regions, and we were in the northwest, the first region to do this sort of analysis, breaking down TB cohort outcomes by level of deprivation. However, it's something that's easily replicable across any region in England. In fact, that data you could easily access. It's publicly available. The main issue would be making sure that data is prospectively collected as part of the TB cohort review process. There's an important point as well. This shouldn't necessarily just be limited to England. Other countries that do activities such as TB cohort review or other such cohort review could stratify on levels of deprivation to identify gaps as well. Yeah.
Peter, there seems to be a very close link between migration and poverty from the data that you showed. Can you foresee what the future of that's going to be? Is that going to remain linked? Obviously, we don't know what the future of migration is, but there's going to be a great pressure for migration in the future.
Yeah, thanks, Mark. You're asking me to use my crystal ball in very uncertain times. So, I suspect from what we've been hearing that levels of migration will continue as they are, and certainly levels of migration from high TB incidence countries will probably stay relatively similar. I think it's interesting to see the data on pre-immigration screening and how that has contributed to decreasing rates of new TB cases in the northwest of England. And I, having been to some presentations about pre-entry screening during this conference, I suspect that will continue to contribute. Public Health England, along with lots of other services, have also began pilot services across the country, screening new entrants using IGRA for latent TB and offering preventive therapy. So those data should hopefully start to become available in the next year or so, looking at coverage. And Liverpool is one of the sites that is now beginning to implement or post-entry screening for latent tuberculosis. So we will be interested to see that data.
Is it likely that things are going to get worse, do you think? You showed that the levels of deprivation between 2010 and 2015 didn't change. Yeah. The impression, an objective impression, is that homelessness in particular is becoming more common. Historically, we didn't have a big homeless problem in the northwest. It was much less than in London, but just from my own observations, it appears this is a growing problem. We know that the gap between the rich and the poor in this country, instead of narrowing, is widening. So is this a problem that it's actually going to grow?
Again, it's difficult to speculate, but my impression is that yes, we are in really precarious times in England. And when there is a lot of uncertainty and a lot of political upheaval, it's the people at the bottom of the pile who tend to do worse, and certainly disadvantage seems to get worse as well. And my fear is that we will have, sustained government cuts to local services in places like Liverpool, Manchester, Preston, etc., where we already have people living right on the edge, and rates of use of food banks have been going up substantially. We've got people who are hungry, families who are unable to stay in their house. I'm worried that those social risk factors for TB are only going to be worse, and that will contribute to increased rates of TB, but also increased outbreaks amongst vulnerable groups as well.
You've got a question, Mango?
Yes. Can you? I've been listening to what you've been saying. It's based on England. There is anything you can talk about our colleagues from other countries? Do you think there is any way that they can use or they can copy what you've been doing here in other countries?
Thank you, Manga. So if I understood the question, it was, can you do these sorts of analyses in other countries? Was that right? Yeah, so I've done a lot of work in Blantyre and Malawi. You may think Blantyre, extremely poor country, probably one of the 5 poorest countries in the world. But even within places like Malawi and within Blantyre, there are spectrums of poverty. You have, we've done quite a lot of work dividing individuals up onto quintiles based on asset ownership or the amount of loans that they have to take out to sustain their family. Tom, I know, has done a lot of work in Peru, another high incidence area, and has shown that those most deprived individuals tend to find it hardest to access TB services and also to sustain themselves on TB treatment and have a successful TB outcome once they've been diagnosed. So absolutely, I mean, a lot of this work just hasn't been done that well across the world yet. There's a huge need to do that formative assessment work. But I think if you do that work, you will undoubtedly find huge disparities between those most deprived. And
so are you saying that any colleague in this room today may come and see you then, in case of advice?
Absolutely, I'd welcome that, yeah. Thanks, Mango. That's a leading question, but yes.
Oh, one last question.
Hi, thanks for your talk. My name's Mel. I'm a clinician at the Birmingham Chest Clinic, not far from here. I just wanted to explore what your feelings were about the actual link between deprivation and migration, in that we find in Birmingham migrants aren't necessarily the most deprived, and if you were to assess outcomes, not by deprivation but social risk factors, for example, they may not overlap and you might get a different graph. So I don't know more recently whether it's new migrants who are deprived or you know, it's a bit of a complicated picture, but if you were to analyse it in a different way, whether deprivation would not be the strongest indicator of poor outcomes.
Yeah, no, I think it's a really good point. And again, it speaks to the fact that there is, you know, we can't just lump everybody together and say you're deprived, you're going to do worse. There is interacting factors within all groups of people. There may be people who live in deprived areas who are not migrant populations who have substantial, you know, high prevalences of social risk factors. I think particularly speaking to Liverpool, where we have an asylum seeker reception centre. So this is when new entrants enter the UK, they are placed in Liverpool for about 3 weeks or so and assessed and then dispersed throughout the northwest of England. What our work here in the city has shown is those individuals, those asylum seekers, refugees who are highly vulnerable and often have the highest risk of developing TB, they are often housed within the worst areas of the cities with the poorest quality housing and certainly the poorest access to health services as well. They find it very difficult to register with general practitioners as well. So I think there's a real spectrum, but it's adapting your response to your local epidemiology. Birmingham is undoubtedly different from Liverpool, where we have had historically lower rates of migration from Southeast Asia particularly.
Peter, thank you very much. I think we should move on. Our next speaker is Jenny Mithu, who appears as Jenny Walker on the programme, but she has recently got married and therefore changed her name. So welcome, Jenny. Jenny is going to talk about the role of the multidisciplinary team in managing TB in underserved populations. Jenny is currently doing a PhD in TB work in the community in the Northwest, but prior to that, she was a TB nurse here in Liverpool, so no one is in a better position than her to give this talk. So over to you, Jenny.
Okay. Hi guys. Right, as Mark said, I am a registered nurse. I am still practicing. I work within my local hospital where I live, so I still do clinical shifts. And I was a TB nurse up until 12 months ago, so I'm a year into my PhD. So this presentation is looking at the role of the cohort review, which is something that I helped to set up along with the TB cohort steering committee. And I still attend, usually because there's a free lunch or free tea and coffee, and I am a student, so, you know, it's got to be done. So any questions, you know, just give me a shout. So this is very much from my practical clinical experience. Okay, so basically the history of cohort audit. Cohort audit began in Tanzania in the 1990s. It was also implemented in New York in the 1990s, and it contributed to the increase in completion rates and the reduction in TB and multi-drug resistant TB. It wasn't just cohort audit that was introduced. There was also a lot of additional funding and a lot of additional resources, which contributed to it. London also introduced the TB cohort audit in 2010, and the rates have dramatically reduced in London. Again, there was an awful lot of funding, and it was cohort review or cohort audit alongside other interventions. So the northwest of England as a region introduced cohort audit in 2012. It's a multidisciplinary approach, as Peter said. It's clinical staff, so the doctors are at the coalface, also the TB nurses who are there out in the community seeing these patients in the conditions that they live. Support staff, excuse me, so admin, epidemiologists, kind of all the administrators who are required. There's also a cohort audit coordinator who does the logistics and brings us all together and nags us to fill our forms in. Public Health England, so we get the CCDCs who are responsible for the outbreak management and the overall TB care, and it's fantastic to have their input. We also have commissioners and CCGs, so the people who are responsible for helping fund TB care, so they can actually see where that money goes and what it does. Because as Peter said, the rates of TB are decreasing, so why do we need more money? And that's because the complexity of our cases are actually going up. The rates are going down, but the complexity is increasing. So these patients need more social input, they need more resources and more access to funds. It's also attended by students from Public Health England, so we get trainee consultants, and also from the university, namely me, because it's free tea and coffee. So, but people are very welcome. We don't actually have patient attendance at it, but that is something that could potentially be looked at. But at the moment, the MDT focus is around sort of the clinical staff. There's no patient identifiable information given, so we take away all names and it's very anonymised. So, cohort audit in the northwest of England. It was recommended in the NICE guidelines and from the Royal College of Nursing guidelines. It's a large-scale audit of all TB cases through case presentation. It's diverse geography, and Peter stole my thing. I've pointed out where we are, and it took me an hour to put that arrow thing on. So, as Peter said before, Cumbria, which is at the very top, is a very rural area. And when you look at the demographics of our patients, it is very different in each footprint, and even within each footprint. Merseyside, for example, and Cheshire, we form one footprint. Merseyside, in its own, has a very dynamic and different caseload. We have inner city Liverpool. We also cover as far up as Southport, and anyone who's from the UK, Southport's considered to be quite rich, quite well off. It's a retirement centre. It's very beautiful houses, but there's also a very big migrant work population, like farm population. So the people we look after vary, birth to death and beyond. Every walk of life, you name it, we've seen it. There's 4 meetings in each geographical footprint every year, so there's 16 meetings every year, and it's encouraged that people cross over, build them networks, and then we learn how other teams do things, because quite often, if we're tackling a problem, somebody else has already had that problem, so we interlink with it. And there's usually between 500 and 700 cases discussed annually since the start of cohort audit. So what do we actually do? Why do we do it? Do we all just go for the free tea and coffee? No, that's just me. So we go to support comprehensive case management procedures for all TB patients. Cohort audit has improved diagnostics. It's also improved interventions. HIV testing in one of the footprints when we started was dramatically reduced, and since then it's improved, and that's through education, peer support and engagement, and basically encouraging people to stick to the guidelines and understanding that evidence base. So we also want to address delays in the interventions in the diagnostic procedure. This can be a case of surgeons putting samples in formalin, and then the medics will go back and the nursing staff, and it's around encouraging, to think TB, to encourage the GPs. If somebody's got a fantastic way of disseminating information to the GP service, sharing that information. And it provides measurable and comparable results of treatment outcomes and contact investigation efforts, which is something that's quite new. It's very difficult to coordinate the cohort, the contact tracing. It's not something that's really been done before cohort audit. It was all very much anecdotal evidence, and there's all of that data-rich information now within the things that we can actually use to coincide with national guidelines. So we identify and tackle important case management issues from an MDT approach. Doctors and nurses see things in very different lights. We think differently, and I'm guessing the majority of the audience are doctors, but we think very differently too, yeah. We as nurses approach problems and issues very differently to the medical staff, and that's a really good thing. And it's fantastic that we have the CCDCs from Public Health England in and the epidemiologists, because they think completely differently to all of us again, which is brilliant. It also gives the staff a forum for open discussion. It's great the amount of times the nurses or the doctors have come with a concern or a problem or not quite knowing how to tackle things. It's very non-judgmental. We don't go expecting to be told off because this patient was lost to follow-up or this patient developed a resistance. We go looking for help and advice, and we take questions to the floor and ask for, has anybody got any input? And that's fed around all four footprints. It improves and enhances the quality and timeliness of data entered onto the national database. The TB nursing teams predominantly are the ones who input the data onto the national database. There's very few nurses in most areas, so actually inputting the data can be a chore in itself. So this helps us to make it a priority so people like Peter have got that data that will be used to implement policies and procedures and resources. And it's networking for all levels of staff on an equal basis. I'm not lower than the doctor. I'm not more important than the doctor. Depends who you speak to, really. We can have that open discussion. We link in. We have fantastic relationships, doctors, nurses, CCDCs, admin, epidemiologists. I've made lots of fantastic acquaintances and people I can go to when I've got a complex patient or if I need a bit of help with this data to prove my theory when I'm taking something to the commissioners. It's absolutely fantastic. So what does it involve? Basically, case notes, so 2 sheets of paper are sent to every TB nurse for their patients who were registered 6 to 9 months before the meeting. So they should have either finished or just be about completing, depending on when it is they were notified. Each case is then rapid fire description, and if it's a straightforward standard case, which very few of them are, bang, 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 done, next. There's open discussion from the chair of the meeting on more interesting or complex cases where we can bat ideas around, share good practice. Excuse me. And there's also, I'd be able to identify gaps. Oh, thank you. There's gaps in the practice or difficulties, and it's discussed in very supportive. There's never a you should have done or why didn't you do. We can often take problems or ask for help and advice, and the chairs will then take that out and deal with problems for us as the nurses that we don't feel like we can take any further. The chairs can take the lead on situations. For example, if a private doctor, a private healthcare doctor has dealt with a situation, maybe not in line with the guidelines and not done best practice, and we as the nurses don't feel like we can tackle it quite as well as a medical member of staff can, they will then take that back and deal with it and feed back to the group. The chairs are both doctors and nurses, again, gives a very different perspectives. The doctors tend to focus quite heavily on the ones I've noticed, on the clinical aspect, and the nurses focus very heavily on the social inequalities aspect and, you know, the practical things of being out in the community when your patient doesn't have a mobile phone and they live on the 3rd floor and never answer the door. So what do the teams get out of Cohort Audit? Why do we do it? Is it a paper exercise? Some people think, oh, God, Cohort Audit, I just haven't got the time. But Public Health England, from a piece of research, qualitative piece of research that was done, some of the feedback that was given was the fact that going through complex cases allows more of an understanding and an appreciation of actual patients, real life patients, not patients in a textbook, not your standard care patient, not your patients who need enhanced case management, real life problems that these people face every day. From a nursing perspective, I found it very difficult. I had a very difficult, very stressful case last year. So when I presented it, the chairperson actually took the control. And they said it was an immense relief for that person to have said to them, you can't do anymore. This now needs to be bigger. You are not in this alone. And quite often, I know my colleagues sat at the back will say, sometimes you do feel alone, especially the community staff, because you don't see your clinical colleagues other than at MDT or cohort review. So sometimes it's just nice to have that tangible somebody that you can say, please help, or for them to say, you've done amazing, we can take this to the next step. So again, PHE, funding awareness. It's about a way of knowing that how funding is obtained for TB control is all negotiated locally, and the information that's provided at Cohort Audit, can be fed back to the commissioners, the people who hold the purse strings, so that they understand the burden of disease. They see the numbers of TB decreasing, but now they can gain an understanding that the complexity of our patients is increasing dramatically. And this, hopefully, will result in additional workforce, whether it be resources, bums on seats, or access to training and facilities. So, and from a medical point of view, the consequences of getting TB care wrong are so high. The financial impact on the service and the patients in wrong TB treatment for MDR compared to standard TBR. We can't afford to not do things properly. And if cohort review prevents one single case of MDR TB in a year, it would more than pay for the cost of the whole cohort review. So again, it boils down to pounds and pence. Can we afford to not do this? So why is TB an issue within the northwest of England? Like I say, the numbers are very small compared to endemic countries and places in the UK like London where the rates are really high. So there is a small number of cases compared to other countries, but the NTB strategy is aiming for the eradication of TB in high resource settings. So working on eradication, as the numbers are decreasing, but to be able to eradicate them, we need to tackle these social inequalities and the risk factors that basically stop our patients from taking them. Very few of the patients that I've looked after and Andy at the back have looked after, it's not that they don't want to complete their treatment, but other things get in the way, whether it's their substance dependence, unstable housing, their inability to work, all these things, they're more important to the patient than the actual TB care, because they don't always comprehend or they can't accept that if their TB gets better, they can get back to work and we can tackle them. They might have nowhere safe to store their medicines if they've got unstable housing. They might sell their medicines for money for drugs and alcohol, which I have seen. It's always really annoying because they sell all of it and don't give you any, so you've got to find a prescription. And difficult cases require an MDT approach to identify and manage eradication of the disease and to help the patient, not eradicate the patient. I'm sure there are some patients we'd all like to eradicate, but that shouldn't say eradicate the patient. And an MDT approach is more than just the doctors and the nurses and the CCDCs. It's all the other resources that we require. So who else is involved? And this is just a sample from patients that I've looked after, that Andy's looked after, and that people I've picked up from going to the cohort audit. So we've had quite a few cases recently of trafficking and modern slavery. So it's really important that we work with A&E, police, safeguarding teams, both adult and children. There's been quite a few patients recently who've got no resource to public funding, and there's now teams been set up and links to that the TB services within certain areas are linking in with to try and shorten that divide. Social inclusion teams are fantastic because if we link with them, they can help us get into the community and raise the profile of TB and try and reduce that stigma. Because if you speak to a lot of people in the UK, lay people who don't work within TB, even healthcare professionals will say TB, that was eradicated years ago. We don't have TB in this country. And actually we do. Interpreting services, really, really vital. They've got their pros and cons, whether it's face-to-face or over the telephone, and it's tackling that. And the prison service as well, because quite often the prison service within the UK is a bit of a nightmare, and prisoners are often transferred or released and the TB teams are not notified, and we get a lot of loss to follow-up or delays in treatment or breaks in treatment. And also immigration services. Like Peter said, Liverpool does house a lot of asylum seekers, and I know from personal experience they move them and don't tell you. Then they haven't got a forwarding address. Oh, this person, Mr. Smith, he's gone to Birmingham. Can you give us his address? Oh, I haven't got it. I don't know where he's gone. And they've got infective TB. And also, we need to work with hard-to-reach groups, so social inclusion teams, again, interpreting services, community leaders to understand what the issues are within that community and around education as well, voluntary sector workers, HIV teams, and sexual health services, as well as Public Health England. Public Health England are fantastic at giving us that overall view when we're so close to the patient. Sometimes you can't see the wood for the trees. So the next step in completing care, in complex care and cohort audit. So we're expanding the research to the effectiveness of cohort audit in order to identify the needs of the patient. We're looking at research in the effectiveness of contact tracing in line with the new NICE guidelines around do we or don't we screen contacts of non-infectious TB. We also use this data to benchmark against local and national standards. And we need to disseminate these findings to the TB control boards, commissioners, CCGs, to improve the skill mix and staffing levels for active TB care, screening, education and engagement with other healthcare professionals and communities, because it's not just around treating the person with TB, it's all the prevention work and the education that's vital to bring TB out of the stigma that it's in, and for people to realise that it is a condition, so you don't get hospital staff phoning you up saying, do I need to give this patient plastic knives and forks because they've got TB? And yes, I was asked that within the last 5 years. It's quite shocking, really, and you're like, no. And, you know, assuming everybody needs to be locked away in a side room and you need a full bubble suit to look after them, because you do get that, because people have got no preconceptions around TB. So just very quickly, socially complex patients, and this is somebody that we see, this is our normal. So a 36-year-old Polish man with smear-positive pulmonary TB, no access to public funds at all, unstable housing, has had episodes of homelessness, a lot of sofa surfing, and when people find out you've got TB, they quite often won't house you. Alcohol dependent, again, that's quite normal for a lot of our patients. Was lost to follow up upon discharge as evicted from a friend's dwelling due to the stigma. And it was noted a cohort review about this patient surfacing in a different area of the Northwest. So the two teams linked together to establish, they already had them networks due to cohort review. We know the teams, we know we can ring them up and go, oh, Leslie, do me a favour, I've got this patient who's staying in your area, can you go and check on them? It's not a big formal referral, we're all really close-knit community. The patient was found and was admitted to hospital because they were clinically unwell. And the teams liaised with each other to gain access to funding for accommodation for the course of the treatment. The team that were caring for that patient had no experience of the systems that they needed to be involved in. The other team had been through a similar procedure with another patient, and they could, sometimes it's not what you know, it's who you know and who you've got the phone number for. So it was around sharing that information and that good practice that worked, and saying, don't bother with them, that bit didn't work. So the patient eventually completed their treatment and was discharged. References, there you go, done. No
Thank
difficult
you.
Questions, please.
Thank you very much, Jenny. Peter has a question. Mango stole it earlier. These people who come from Birmingham, that's the problem.
Yeah, Birmingham, we can't trust them. You hinted at but didn't cover enhanced case management. Do you want to say something about that?
Yeah, I can do. So basically, enhanced case management, the Royal College of Nursing set out a standard care plan for a standard patient. I don't know about you guys, but in the session yesterday, me, Andy and his colleague and myself, we worked out that we reckon about 2 out of 70 cases are standard. So instead of having a very binary standard case management or needs additional support, what we did as part of the cohort steering committee was to establish how much input does that patient require from a nursing perspective. And it was a time continuum, how much input from a TB perspective, so from a clinical perspective, from social needs, so whether it's, they need support with the housing, the finances and things like that, and TB specific issues, so things like stigma, how do we just have to do education with the patient, do we do education with the family, or is it a bigger circle maybe? It could be a community group or within a religious setting. So we did that, and what we did was we basically graded it from 0 to 3. 0 was your typical standard patient. who you basically saw once a month, checked they were okay, they converted from smear positive to smear negative, so at the end of 6 months, and they were discharged, no problems. Your level 1s, where they needed a little bit more input, or their family might have needed a little bit more input as the caregivers. Level 2 is slightly more complex, and level 3 is your chaotic patients, your patients who, you know, you can't find an interpreter who speaks their language, and it's not safe to use family members due to stigma or adult protection issues. Something as simple as not being able to get an interpreter can result in that patient defaulting on treatment because they don't understand how to take their medications. So things like that can cause a lot of additional nurse time to be required. So the next phase that we're moving on to, which is part of what my PhD is to interview the patients and to look at a qualitative perspective of what their issues are and what they feel has impacted on their ability to either complete or not complete treatment. So we've looked at the nursing time required, so we're now moving on to the patient perspective.
The majority of people need 2 or 3.
They do. It's on my presentation yesterday, it showed that when we basically categorised them as standard case management or enhanced case management from the RCN guidelines, I think it was about 60% of cases were standard. And actually, when we dug down and we realised how much we actually do, it's now in the region of 25% of cases are standard, and about 75% of cases need some form of additional input. And it's about 60% require higher levels of support and assistance.
Okay, one more question.
Hello, my name's Annabelle Cannabis, and I'm the editor of the TB Facts website. On your last slide, I think it was, you had about your patient being admitted to hospital.
Yes.
Now, in the UK, hospitals are coming under increasing pressure financially, and are not always now able to admit patients when they want to. Has this started to affect you yet, or are you still all right with this?
It is a problem. We have, across all of the footprints, there's been cases recently where patients, there's been nowhere to send them. When they've been in hospital, they've been diagnosed or they've been readmitted for clinical reasons because they're unwell, then there's nowhere to send them because they've got no recourse to public funds. In the 2 of the cohort reviews that I've just attended, I can't remember if they were both in the same cohort review or if they were in 2 separate ones. There was 2 cases where the patients had nowhere to go. There was nowhere safe to discharge them to. So they do end up sitting in a hospital bed when they don't clinically need to be there. So yes, it is a problem. And then obviously there's a backfill. You know, there's a backlog of patients who need that bed for a clinical reason.
I think that's about difficulty getting patients home, but the question was also about, is the difficulty getting patients into hospital? Is there space to put them when you want to get them?
No, there
in?
isn't space
Not
to
so
put
far.
them.
No.
Really, there isn't space to put them, is the short answer.
Okay, Jenny, thank you very much. Excellent.
Thank you very much. Let me introduce the third and probably last speaker, Manko Hoto. He will be looking at the patients' perceptions of barriers to access to TB care and involvement of civil society in the TB control strategy. Thank you.
Before I speak, I would like to know how many patients are here. Nobody. So no one is a patient. Anyone from state sector organization like Jenny, I forgot your name, it's not good. I believe that you are working with some organization in Liverpool. Is there any of them here? No. So exactly, this is where I'm coming. This is where we need to open our eyes. We need to think again. Are we on a track? Are we writing essay? Because sometimes we may be writing essay and thinking we are resolving problem. And I've been here since Saturday, not as a patient. I've been here just to support the union. And the reason is because the union now is here in England, and we are here, we are promoting TB, we should be supporting the union because they don't have enough money to recruit a company to do volunteering job we did. And we help you guys. Anything you add in your bags, 3,000 books, we did that, free of charge. You can see, I've seen a third sector organization from Liverpool doing that job. The age between young to 65 years old. And these people, they don't need to be there because it's not their business. They should be staying at home. The union should be paying money. But because they believe they are third sectors, they believe that they are civil society, they believe that they can do things for free, they did come Saturday to Saturday. If you look at my voice has gone, even my eyes are red because of waking from room 1, 2, 3, 4, 5 to 11. Anyway, all I'm going to talk today about is everything I've listened is all about people who went to university, people who knows how to write essay, people who knows how to analyze things. And we've seen it, all of us. And some of them, between me and you, are boring. Sorry, I said when I came here that we don't need to be coming to union anymore or to this kind of conferences to be being like a professor. Anyone is a professor here? Sorry, like going to university, people sitting there and then listening to one person talking. This kind of conversation should be something interactive. So my PowerPoint and everything, let's talk about it. What is going on? What kind of barrier are we facing? Now, the first point is this. Okay. I talk about academic. This is academic as well. So the reason I put that on is to show you exactly those, I don't know if this will work. Oh, I can't see. Anyway, I don't know how to do it. There is a ping point there. You're not here. Yes, thank you. So,
the green doesn't show up very well.
Oh, yes, I see. Okay, background. So, if you look at all of those red area, and then you see the map of England, you will see Birmingham, you will see London. So, I'm talking about West Midland. You will see even the small city of Leicester. And then academic, we are saying that those are red area. Those are no-go zone. Very dangerous. That means TB is there. Who lives there? Human beings like you and I. So the issue of migrant population, issue of underserved population, even that word underserved, I have to tell you, I'm lucky to be part of nice guidelines, and I'm lucky to be part of nice quality standard for tuberculosis. I'm always saying to them, those big words, underserved, why not leave it hard to reach? Those things, they are not like a joke. It's people, human beings, who can't do nothing by themselves because of the system we are living in. Now, my second point is this. If you look at nice guidelines, the reason, I need to come back here. When I was writing this PowerPoint, I thought I would have some people from different countries. I've seen some out there. So I said, let me tell them about the way the NHS here work and what is the NHS. That's why I add my PowerPoint to tell them how everything is free in this country we're living. When in your country, consultation you must pay, screening you need to pay, maternity and everything you need to pay. In the UK, it's completely free of charge. Now, the question they sent me on email to address was the barriers. And when I was thinking about the barriers, people think money, houses, but the big barrier is this. Because in England, anywhere you go, I was sitting 2 days ago, I think, no, yesterday, and listening to presentation from Netherlands. All they are saying is mainly people born outside Europe, they are the one affected by TB. And here in England, in our guidelines, we are saying the same. Now the question would be, who are their people? If you look at my before, I talk about the system. And now, who are the people? We are talking, and why are they affected? Now, if I ask that question, nobody going to reply. I can reply to that because I live with them. So because we live with them, I can reply to that. This is the reason. I came in this country in 2002. Arriving in this country, I did not have any English at all. Everything I was speaking was French and my own language. Now, all I have to see is, do you know what? If you're sick, that's the Home Office. If you're sick, go to DP. It's free of charge. Just go. They will treat you. And when I went there, the first thing I saw was what? A man sitting like this. How can I help you? And that word, how can I help you, intimidated me. I'm talking about me here. Now think about Somalian lady. Think about Indian woman who never seen a white face to face. Think about Cambodian lady, refugee, asylum seeker, front of a GP. How can I help you? What can they say? They will be intimidated. They can't say nothing. Sorry, I'm fine. And before you know it, they will give them paracetamol and that's it. I did the same. I had the same. So, lack of all of those things, language, culture, lifestyle, and sometimes, I need to tell you, it's not only people from migrant population. My friends, my brothers and sisters, born here, English, who live on the streets. The law of this land, if I'm not, correct me if I'm wrong, the law of this land says you cannot sleep roof only by your own choice, isn't it? So to sleep roof in England must be your choice. To be homeless, it must be your choice, because if you are homeless, police will take you to an hostel. You've got a national insurance number. They will take you to housing. You are able to work. You must sign on, and they will give you a place to stay. But if you say no, I'm taking drug or alcohol, you can stay out. Therefore, we've got so many of them homeless out there. Now, these people, we need to see how the mechanism, how we can help them. However, the academic came only with a definition, and that is a very long definition. If you can see that definition the way it is, we can reduce it to one word, saying anyone with TB should be supported, regardless of his language, blah, 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 and then just help them without saying people of that and this and that. However, as I said before, it's not only migrant, it's also prisoner. Found in the tree, we went to the prison of Birmingham, and then we found people over there. And for me, I found someone who was a millionaire. We have to screen this person. He looked at me, he cried. He said, do you know what? When I used to be outside, I had low money. People like you, I'll pay you my money. You won't come and help me. So you can be in prison based on small thing because of the law of the land. Now we need to think again. These people are patient. Vulnerable migrant. I put that word vulnerable migrant because not everyone migrant is vulnerable. We need to correct that. Sometimes we think someone who's a refugee is vulnerable. No. Some people, they're coming from a very big background. And maybe they may have money more than you have. But because they are in this land, we tend to say, oh, sorry, I can help you. No. Sometimes we need to give them guidance how they can live their life instead of trying to teach them how they can live. In TB perspective, sometimes I support my colleague who said before that we need sometimes to ask them questions. What do you need? How do you think about your health? Instead of saying, this is the nice guidelines, because he's migrant or she's a migrant, we should treat them this way. So every individual is unique. Now, the engagement approach. I think there's been something with my PowerPoint. That should be the second one. Anyway, now, what is the main problem? When I was given this PowerPoint, this question, I said to myself that the problem is not a human being. The problem is money, resources, the NHS, the national insurance number money goes every time in your pocket, clinician. You've got that money in your bank, and some of you sitting in your bedroom, all you do, just writing something down to justify that money. Meaning what? We've got so many resources. We've got technologies, mobile X-ray. We've got so many stuff. And now there is no possibility to go and see these people. It's become very complex because there is research here, there's so many stuff. And the patient also, all they need, people that we are looking, all they need is someone to trust. They don't need a machine. They don't need screening, or they don't need whatsoever. Somebody to trust, someone who can just listen to them. That is the big problem we have in this country. Even the contact tracing, I know some places they are doing it very fantastic, but because we have a lot to justify, we have a lot of money. For me, as a patient, I'm talking as a patient right here. I think because of that, that's why you've got so many researches, and you can see from several talk, the same things come up. I've seen in conclusion from my colleague who was here before, the same conclusion I've seen several times. As a patient, I think they should look at your money. It's too much. Now, the barriers. The use of the NHS is a big issue. You've got those stuff everywhere. You've got everything, implementation. I can listen to what North East is doing. Birmingham is looking every day. I think two of them are here. They are looking every day the new model, what to do when this finish, what to do every day. London, you tell me, from TB Alert, Finding the Treats, TB Alliance, results only for small disease, which is TB. Yes, it's not bad. But as a patient, from my point of view, I believe, yes, this is okay, but why not to concentrate on helping me on how I can use the NHS effectively? Our patient, all they need someone who can teach them how they can use the NHS effectively. Because the country of their origin is a problem also, is a big barrier. You are coming from Congo, you're coming from Eritrea, and the system, when you come to UK, the first thing you see is free of charge. Before you know, oh, it's free. That means they will kill me maybe. Or, yeah, this is what they do. They refuse. They refuse. They say, no. Well, how come it's free? No, it's not true. So, for me, I would say, teach me. Show me how to do it. I think Chinese people say something about show me how to find a fish instead of giving it to me every time. What we've been doing since I'm in this country, we are only trying to give out. Why not teaching people? Also, personal circumstances. This is very important. As I said, my friends and colleagues who are British or white or you name them, born here, don't know nothing about immigration. They are homeless out there because of substance misuses. Now, I've listened here, one question say, if you know how to engage with a GP, please help. Yes, but I think in this country, we have, as a patient, I believe that we have a paramedic who goes out to those homelesses. Why not to link with them? Because they know them better, so that the screening and the engagement can be quickly. The big issue is, when I was writing again this presentation, I said to myself, I'm not going to be critical, because if you look at, I'm lucky to be reading so many papers from different backgrounds because of the work I work with NICE. And I believe that Birmingham has done so much. I believe Northwest have done so much. Now, there is something we can do there, which I said to myself, if we can involve civil society, that word civil society is very hard to talk about. But let's take third sector organizations, voluntaries, charities. If we can involve them appropriately, that would be fantastic. That is the solution to this problem. And the question I was asking myself when I was writing again is to explain our brothers and sisters who are not from this country that in England, the civil society is charities, third sector organizations. Now, how do we do this? Now, my own experience and the work I've been doing. I'll be talking about something that I have been doing, which I believe, which I can say that I'm here for it. Birmingham is too big, and I've got some things that I will share with you by other topic. However, we used to have four PCT. Please correct me if I'm wrong. 4 PCT before, isn't it? We used to have 4 PCT. South, out of Birmingham, Solihull, and one I miss it, and East Birmingham. Those 4 PCTs used to work. You do there, I do here, you do this. But what happened is we have PCT, CCD now. And we come up with an idea to say, in the grassroots level, we need to figure out how we can introduce homeless population, migrant population, so that they can be working together. They can be part of the solution. We need to figure out how we can come up with something for them to feel welcome. So, what we did, we created this. We said, was one of my colleagues, she was not my idea first. She said to me, everywhere you go in Birmingham or in England, you will see the sign of welcome, everywhere. Welcome to Birmingham, welcome to Liverpool, welcome to Cumbria, welcome to everywhere. Welcome to London, isn't it? So anywhere you go, you find welcome. And some of people say welcome, but now learn English. Excuse me, I'm not a professor. Can we, if anyone can talk something, can say, please, when you look at me like that, I feel like the same station. Let's talk together. Am I lying? Anywhere you go. My friend, did you come here 2 days ago? I'm talking to you, yeah? Did you see sign of welcome in your report? Oh, thank you. Saying what? Where was the conference? So everywhere in England, welcome. And in Birmingham particularly, when you look at the population, when people walk, if you look at them like this, you may think like, I'm in America or in other, this is not Europe, because you see everyone there. You see black, you see white, you see everyone. You see everyone there. So we're becoming one. So the program we designed was to make sure that we can inform, we can educate, we can support, and we can train. It's very easy when I've been trained about something or I've been told about something, and if I make a mistake, I can be judged. However, migrant population in this country, the academic, I've been treating them saying they don't want to go to GP. They don't have GP. But who told you that they knew about GP before to come to this country? Nobody. Oh, they don't want to get screening. In our country, screening is money. Now, if you ask me to give my IGRA blood, I say, where are you going for blood? Isn't it, my friend? because it's not easy. You take my blood. No. Black magic. I'm going to die. Especially it's free of charge. So the program was to change the way things work. Now, why? Only because, you remember 2010. 2010, this country changed. Since I came to this country, 2010, I've seen everything changing. It becoming cut, or it becoming blaming game. Now, every time, every minute, in the radio, on TV, any is full. Any is full. So every time people used to talk about any, oh, there's a delay. Why? Because so many people are queuing. So we said to ourselves, okay, because this is leading to poor outcome, we need to make sure that we're going to develop a program that is going to support the migrant population to understand how the NHS works. Because if you can't speak English, you don't understand the system, you can't do nothing. Now, this yours, when we came here, first thing we see is just paper like this. Who told you that I know how to speak English? Are you with me? So I'm challenging you because this is my job. So when you're going to be doing your core review, when you're going to be writing anything involving migrant and homeless, ask yourself a question. This information I'm giving them, are they going to understand it, yes or not? Look at your fast. Your fast is someone with a very bad face. Do you think I'm going to read that? Although it's good information, fast. But look at how that person look. Can you see that? So this is the way we think. It's not the way you think. Again, look at your 1111. What is that? So we changed that in other way. We said in India, in Papua, in Africa, everybody, they do word of mouth, face to face. If there is a problem, they sit down and they talk. If there is a problem, a sister will come from the village to another village and talk. Instead of paper, let's sit down and talk. So we transform that to workshops, word of mouth system, to make sure that our people knows exactly what's going on. Now, I'm going quickly. Before to do that, there is one lady there, Dr. Enka. Dr. Enka used to be a TB lead for Birmingham for a couple of years, the doctor. And she was very passionate about the program. And then we had community support worker to support them to understand the system, which I would recommend that, if it's possible, that can also be done in here. When they train people, not only in terms of L4TB, they had training on immigration, housing, and benefit, and they became TB champion. The reason beyond was these people will go to the community and support them. LTBI. I'm coming to this conclusion because I will show those other things later. We engage so many people with support from Dr. Uda Mohamed and Dr. Enka. We supported people. They didn't come up with the proposal. We went to them, which I would recommend that the third sector of Northeast to come to you. You need to open your pocket, please, give them money to try and engage with migrant and homeless people. So we went to them. They gave us money to do this job. So we screened 634 people in 1 week. How did we do it? You can see the first picture I show you, Dr. Inka was training people how TB work and how they can go out and explain to people. Now, you can see all the champions sitting there. They are at school, in colleges, training people how about TB, everything, and how they can come for training. Now, I was saying something, I said to myself, if I come from Africa, anywhere in the world, and you ask me, Mango, can you please give me your blood? I would say no. But if I had someone like the lady there, don't worry about it. Just come, give your blood for yourself. I'll agree. So we went there, we trained people, And then the team of, the TB team, including one of the nurses, she's there, they came to the college, they had everything done, and they screen people without problem. I'm telling you, the screening was at the college, not at the hospital. Can we move out of our offices? The patient, all we need you to think the way we think. Forget about analysis sometimes, it's paperwork. Now, we educate, as I said, it was information, it was, okay, the way the ESOL are put there is because when you come here, you must learn English. So the majority of people had to learn English, and then we went to make sure that we can train them and engage with them. You can see there, this is another college. We are inside, in a classroom. This is an event which was done outside. In Africa and Asia, migrant population you want to train or you want to help, they love music. Why not organize a festival for them? If Birmingham did it, why not Northwest? Mobile X-ray. Again, without us, our story cannot come to Birmingham. No. We engage with them, we support them so that they can come and they can screen people. You can see out there, we are outside Birmingham. We are not in the office. We are on the street. The van is there. And everyone wearing the white are part of our organization to support migrant population and homeless people. This can be replicated elsewhere. Policies...
I'm sorry to interrupt. We need to try and wind things up.
Okay, I need to finish quickly because I didn't the time and everything. Okay, in the policy level, we are part of the NICE. And other people like Alstory, they do so many things. So patient and civil society, they are doing so much. I need to say this. This presentation was about the way we work. Based on everything and collaboration, TB in Birmingham, they've got somebody support worker. I can listen to what you are saying here, that maybe sometimes you need somebody who can come and support you for housings. We can learn from other people what they are doing. Again, in old age, they used to use us. They will come, they will take our ideas, and they will go. Now we are happy, because anytime there's anything, we are part of the team. In new age now, in Birmingham, I can tell you, they will consult us from beginning. We are not anymore, but you and us, we are part of one team. Now, this photo I put it there, the last one is this one. The idea of welcome to Birmingham came here. You can see this is a photo from the WHO in one of African countries, the way they engage in that country. And you can see back, this is the same way we brought up here to engage. I'm not going to go further to my talk. I need to wrap up. Why I'm here today? One, please, the third sector of your city, they are the most important and they've got expertise. Two, engage with them as partners, not you and them. And three, your patient can be encouraged so that they can be taking part of what you're doing. In core review, why not to invite one third sector? Thank you very much. I don't have enough time to continue everything because we had to close. All I can say, thank you very much. Any question, I'm here to reply.
Mango, that was great. I think the message is clear that we need to engage, and you gave us some ideas about how we should be doing that in the future, and the Birmingham model sounds great. We have to close the session now, but if you have any questions, I'm sure Mango will be here for a few minutes. Please come and talk to him, because he's got a vast amount of wisdom in this area, which would be very, very helpful to all of you. I'd like to thank my co-chairman, Isaiah. I'd like to thank Peter and Jenny for the other presentations. I'd like to thank Tom who organised all of this today. So well done, Tom, and thank you all for coming to this session in the conference. Thank you.